First, I'd like to introduce Dr. Karen Benattar, who's the registrar at our clinic here in Hamilton, and she's going to be supported with Dr. Jane Morgan for short questions afterwards. Thank you.
I'm going to talk today about a project that I did last year, and really about the impact it's had on our practice. There were two main reasons why I proposed to look at this subject. Firstly, we were seeing a fairly rapid increase in transgender clients coming to Hamilton Sexual Health Clinic looking for help with transitioning, and particularly for hormone prescribing. And sorry, is that better?
Yeah.
And the second reason was that there were some new guidelines developed specifically for New Zealand, and I really wanted to see how what we were doing compared to what the guidelines recommended, which was a little unfair in a way because most of the notes I reviewed were consultations that happened before the guidelines had come out. But we had previously been using overseas guidelines. So, first of all, I'd just like to say that I understand, particularly in this field, that words are really important. I'm using the word trans or transgender to refer to someone whose inherent gender identity is different from their sex assigned at birth. I recognise that there are many other terms or words that people choose to use to describe themselves, but for the sake of this talk I'm going to use the word trans or transgender just purely out of convenience really, because I need to have an overall term. So the guidelines, there was in 2007 the New Zealand Human Rights Commission held an inquiry into discrimination experienced by transgender people. It's called To Be Who I Am, and if you want, it's very well written and worth reading. And as a result of that, one of the recommendations was that we needed to have better access to health reassignment services. And so they were commissioned to lead a project to help clinicians in New Zealand have better practice. So what I did was I reviewed the notes of all the clients who had transgender or transgender issues or something similar recorded as a diagnosis code or a reason for their visit. Not as their gender identity, but as a reason for why they come to us. And I used the New Zealand guidelines as the audit standard, and I also looked at a couple of other things that I became interested in as time went on. So really baseline data in terms of age, ethnicity, number of times they came to the clinic, who had referred them, medical history, smoking, alcohol and drug use, and whether we followed the guidelines in terms of measuring their weight and height, and doing blood tests, and how we provided information and what sort of consent procedures we had. So there were 31 clients whose notes I looked at, and of these 3 were female to male and 27 were male to female. That's a ratio of 9 to 1. That's a higher ratio than other published studies in other clinics, which have been more like 4 to 1 or 2.3 to 1. You can see from the graph how steeply the numbers had increased just in the preceding 2 years. And that was probably for a variety of reasons, but predominantly the lack of other services or the closure of other possible places to access this sort of treatment in our locality. They were mainly young and so aged in their late teens or 20s, but there was another cluster of people in their 40s and 50s. Looking at ethnicity, 45% we saw were Māori. In our DHB population locally, it's about 20, Māori make up about 20% of the population. And yeah, there are a variety of possible reasons why that may be, not just in sort of cultural comfort in terms of being transgender, but maybe also cost in terms of accessing other services. So treatment. Of the people that we saw, 11 clients had at least one prescription from us. 5 clients were on hormone treatment prescribed elsewhere, and about half the clients, so 15, were not on any hormone therapy. 2 clients had gender reassignment surgery over that time. Okay, so psychological assessment or support. There are a few aspects to this. Firstly, the guidelines recommend that a diagnosis is made. And that is a diagnosis of, in the guidelines it's talked about as gender identity disorder, that's the DSM-4 criteria, or in the new DSM-5 have a diagnosis of gender dysphoria. There are many trans people who feel that they do not have a mental illness and do not want a diagnosis, but in the American setting they need a diagnosis to access care, and I guess we need to know that we also need to know that going onto hormone treatment is appropriate for them. There's a second recommendation that people go through 3 months of psychotherapy or 3 months of real life experience in their desired gender. And so that's another reason to have some psychological expertise. And thirdly, going through that transition is hugely stressful. And we know that trans people have higher rates than the general population of mental health problems, often due to the discrimination that they experience through school, through workplaces, and through accessing health services in general. So that's another reason to have good ongoing psychological support. So of our clients, 6 had a full psychological assessment as recommended in the way that's recommended in the guidelines. 2 had a partial assessment. 8 were referred to a psychologist or other mental health professional, and we didn't have a reply. So we don't know whether they just didn't go, but that seems to be likely. For half of our clients, there was no psychologist or other mental health professional involvement. I looked at STI screening and blood-borne virus screening. You can see the numbers up there. We weren't that impressed with how we did. We're a sexual health clinic after all. But there are some barriers in terms of time and in terms of people's comfort around exposing their body. And so that's something we can certainly improve on, looking at maybe using self-taken swabs perhaps more. The other thing that struck me was how many people only came once or twice. Yes, we've had a lot of new clients, and so maybe they hadn't had time to be more than once or twice. But why were so many people only coming once or twice to see us? Why weren't there so many in the groups with ongoing follow-up? Okay, so the guidelines have some baseline initial assessment recommendations, and we did pretty well on those. The glaringly obvious one that we didn't was height. At the time, our height chart, you had to go down these windy, steep stairs. It's another part of the clinic. So, but we hadn't kind of really thought about it until you actually look at your notes. Okay, so the guidelines do recommend that those who start on hormones have some written information, and that hadn't really been our practice. We were mostly using verbal information, and consent as well, though it's recommended it's a written consent, and we had mainly been using more of a verbal consent. And for half of the clients that we started on hormone treatment, we had documented that we discussed fertility preservation and given them information about it. So back to the psychological assessment, and this is really specifically for those who we prescribe hormones for. So we actually only really managed that formal psychological assessment for a third, partially for another. Now the other 6 people who received hormone prescribing from us, some of those had come from other areas, so they would have gone through this process elsewhere. But there were certainly some where a decision was made that hormone treatment was appropriate without full psychological assessment. Monitoring afterwards, so there are, again, the guidelines give clear recommendations about how often to monitor blood pressure, blood tests. So in general, most of these things were done, perhaps not as the 3 monthly intervals that were recommended, but probably more like 6 monthly, except for reviewing smoking and alcohol and drug use. We weren't as good. Perhaps we asked, but we didn't document it. So I was interested to see why half of the people that came to speak to us about this didn't have hormone treatment. So there were 15 people. Of those, about half were referred to a mental health professional for assessment and then didn't come back, and we didn't have a report back from the mental health professional. They disappeared. 2 at the time of the study were still going through their fertility preservation procedures. 3 people were referred to endocrinology. I suspect these were all female to male who, and endocrinology at one stage were accepting those referrals and then don't. And there's another 3 other reasons. So we met as a group, and there were a few questions that needed to be answered as a result. Why were people only coming to 1 or 2 appointments? Clearly we needed to try and improve our rates of STI screening and HIV testing. We really needed another height chart. Something so simple. But can make a difference. We needed to have our information for clients on hand so that it was there to give them, and we wanted to have easily available consent forms so that we weren't always trying to do things the hard way every time. And then the big discussion was, what do we do about psychological assessment? It was obviously a barrier. There were 7 people that went off and just never came back again. At the time, we were referring to a private psychologist who had a special interest, but there was a huge cost barrier. The DHB mental health services would only see trans people for another mental health, for a mental health problem that was severe enough to merit their involvement. And so this was really we saw as the biggest issue, really. So what have we done since then? It was about a year ago now, I think, that we had that conversation. So what we've tried to do is increase access to counselling and other psychological support by liaison with a variety of local providers. So a variety of different ways that we've thought around this issue to try and help people access the support that they need. Well, the height chart bit should have been easy, but it was actually quite hard, isn't it? We have now printed consent forms, the fertility preservation info. It's all there in a folder in the clinic. It's very easy to hand to people. We've made some tentative first steps in prescribing testosterone treatment because it seemed like no one else in our locality was going to. And our transgender client numbers have continued to grow. So last year we had 7 further new clients, so we had 11 in total, and we've already had 10 new clients since the beginning of this year. What would we like to do next? Well, we would like to consult with the trans community. I think that would be really valuable. We have got the beginnings of some collaboration with a liaison psychiatrist in the DHB who will be able to do colour assessments. We're still learning. We still have lots of clinical questions around this, and we will review our notes again and see how we're doing in all of those areas.